Okay, well, good evening, everybody. We are in the process now of making yet another video to send out to all of our DCF staff. We have with us Commissioner Vannessa Dorantes, who should be on the left side of your
Right, guys.
screen. And we are joined by Dr. Nicole Taylor, our medical director for the department, who is going to be here to ask some specific questions, or actually answer specific questions pertaining to our COVID-19 planning and specifically the virus. My name is Ken Mysogland. I'll be talking with the commissioner and Dr. Taylor this evening. So, Commissioner Dorantes, could you explain to the staff and review what actions that we have taken upon your leadership to balance really the mission of protecting children with the safety and health of our workforce?
Yeah, Ken, this is tough because like no time before in our history have we had to experience something like this. So if you've watched any of the other videos that we've put out, really kind of talking us through the last couple of weeks of just rapid fire planning, from mitigation of this pandemic to really just trying to understand how our work fits in the context of all this. It's been tough. Every single decision that I've made has had the workforce at the forefront. It may not seem like that at times because when you're impacted personally, as all of us have been, some members of our workforce have been impacted in ways that none of you could really even understand and fathom. And so we're going to talk a little bit as we chat tonight about some of the things that we have done pretty routinely to make sure that we keep the interest of the workforce forefront in our planning for making sure kids and families are okay during all of this.
Right. So we're doing this video now. It's actually April 7th. And Dr. Taylor, I wanted to ask you, when did the department first learn about COVID-19? I guess that would be through the World Health Organization. And can you walk us through some of those initial steps in our early planning?
Thanks, Ken. So, as you may be aware, the World Health Organization learned about this new COVID virus that caused pneumonia December 31st, 2019. The first cases in the United States was discovered from travel in January 21st, 2020. The department was aware of it, but had our first meeting for planning January 28, 2020, and started drafting our first memo for staff returning to work. So we've been planning with guidance from the CDC, from the time that the WHO learned about this new coronavirus infection.
Right. Thank you for that. And Commissioner, in your daily work, you consult with many individuals, both internally and externally to the department, to ensure that we are reinforcing with our staff best practices as advised by the CDC and DPH. Can you explain a little bit about who you interact with on a daily basis?
Yeah, and thinking about when Dr. Taylor gives that timeline, man, has a lot changed since then. In the beginning, we were just thinking about, who maybe has traveled out of the country. And now I am in daily conversation in the Governor's Unified Command. It's the emergency preparedness response that the state stands up whenever we are in a disaster or a crisis situation, such as.
Uh-oh. Looks like the commissioner froze a little bit here for us. Let's see if we can get her back. Just hold on one sec. Dr. Taylor, just one other point as you were talking about the history of the virus and notification. Can you explain a little bit to our staff the difference between the Centers for Disease Control guidance and maybe where the Department of Public Health fits into advising our specific department?
Sure. So the Center of Disease and Control and Prevention in conjunction with Connecticut DPH, works together to create guidance for multiple different aspects to this, our response to the virus. And I can't stress enough what the commissioner just said about this being an ever-changing situation because of the newness of this virus. Now, there has been some similar viruses that we've had experience with, but similar is not the same as being exactly the same. So our experiences are very new. We work together with the CDC based on their guidelines, and the commissioner and myself personally have worked together with the Connecticut Department of Public Health when we craft our response or use the guidelines as our work in protecting our employees as well as protecting the clients that we serve.
Sure. So we really use the experts on a national level, and then consult with the experts internally to Connecticut to inform our best practice.
Absolutely.
Okay. Commissioner, we have you back. You froze temporarily, right?
Yeah.
We have you back, and I think where we lost you is you were discussing the internal and external individuals that you consult with. And when we lost you for a moment, I actually asked Dr. Taylor to explain the difference between the CDC and the Department of Public Health. But I think there's you have internal command meetings, external. Maybe you could pick up back there with us.
So I do want to just highlight the fact that this has created this kind of virtual world that we are forced to live in now has created challenges. Our IT department, along with our CT Kind folks who have come offline to really help with connecting folks, and our Academy for Workforce Development have worked really hard to get as much connectivity as possible. So we currently now have over 2,800 staff members, 2,831 to be exact, or 81% of our staff teleworking. And so what you just saw in terms of my video feed freezing is some of the technical challenges that come with this many people kind of being online and working through some of the technical challenges. We appreciate everyone's patience as as we work out some of this. Some of this are things that we can troubleshoot, while other parts of this are just part of just this larger societal issue of trying to learn how to do work remotely. So what I was saying before I froze was that part of our everyday command is that having an internal dialogue with all of the department leaders across the state of DCF, across our divisions, our facilities, our area offices, to really make sure that DCF's divisions and departments are aligned with each other. And then I also participate in the Governor's Unified Command, which stakeholders across the state talk about different parts of this preparedness and response to COVID-19. So, as a part of all of those moving parts, my days are probably about 12 hours each day. And there's no weekends in that. We've been working through the weekend to make sure that the department's needs for our staff and for our families are right in the forefront of those conversations. And then on top of that, I've had conversations regularly and weekly with the regional child welfare leads in the New England states. And tomorrow I am presenting Connecticut's plan and Connecticut's strategy and how we've been working to a webinar of about 200 jurisdictional leaders across the country on just the COVID response as it relates to child welfare.
And what a great honor that is for Connecticut, and especially you, Commissioner, as our leader, to be able to present to your peers across the country about Connecticut's planning, and hopefully impart some knowledge to other jurisdictions, while at the same time learn from other states across the country and their best practices as well.
Yeah, no, we are so fortunate to have the team we have here in Connecticut. It's easy to talk about the work that we do because everyone's working so hard to make sure that the mission of the agency continues to move forward, and expertise like Dr. Taylor to help guide us through making sure that we align ourselves with the CDC and the local public health authorities to, really respond in a way that is consistent with what is needed here.
So we know the virus is in the community transmission phase. It is throughout all of our communities in Connecticut. Connecticut, in its close proximity to New York, has put us in a very difficult spot. So I guess one of the questions that we really want to clarify for all of our staff um, is first and foremost, what occurs when it is learned that one of our own staff members has tested positive for a COVID-19 virus? And then a follow-up question to that is, Dr. Taylor, can you also explain to us what contact tracing is? So first of all,
Yes.
Commissioner, what is the process when we are notified one of our staff has a positive COVID-19 diagnosis, which is the best way to frame that question?
Yeah, we put together a team right away that started to make sure that we consistently had a process to follow every single time one of our staff members received a positive diagnosis. And Dr. Taylor was a part of us crafting a protocol that included the exec team. My whole team comes together immediately, along with the medical director. We have the chief of engineering, who kind of helps with the security, the cleaning, and the supplies that are needed. We have our Bureau Chief of Child Welfare to talk about the impact to the area offices. We have the Assistant Chiefs of Child Welfare participate in terms of really helping to coordinate if one office has to be shut down and another office had to pick up. We have the facility superintendents that have been a part of those immediate calls. And then we have human resources who helps us really try to understand just the amount of contact and the amount of leave that a particular staff person has to go. And they have their own protocol that they've been following. And we can disseminate that out to everybody, because I do think that as soon as you've heard that someone in your local area has tested positive, immediately people got very worried and concerned, one for their colleague, but then also their own health. And this is where, the use of this standard practice that Dr. Taylor has helped us stay consistent with has been our just template for every single time treating these as each individual case, but having a solid set of terms, expectations, and guidance and guidelines that we use. So, people use the term exposure or exposed, or use some of the same equipment, or some of those things that people may believe put them at higher risk for acquiring the disease. But I want you to rest assured that this process that we've used really takes into account not only the national guidance, but the statewide guidance that we review just almost daily. And I'm going to talk, after Dr. Taylor talks a little bit about what that process is about and what contact tracing is, I'll talk a little bit about our communication on that as it relates to staff, because I think it's important to share some of that too.
Great. So that team that gets together, Commissioners, led by you, includes the executive team, our chief fiscal officer, who also oversees engineering, as you indicated, responsible for the cleaning and the supplies, as well as security. We have the Bureau Chief of Child Welfare, Assistant Chief of Child Welfare. Also, if the individual resides in a facility or 24-hour operation, we have our facility superintendents, perhaps our care line director as necessary, human resources. So we've got, and Dr. Taylor. So the question then becomes, who is the individual first and foremost? How can we support our staff member who now has this positive diagnosis? But then what is the process, Dr. Taylor, to determine if our employee who has a positive diagnosis may have been around others who now face or are facing possible exposure? Can you explain that process?
Sure. So we use the guidelines by the CDC as well as DPH, and I have to stress that we apply it very cautiously, in the sense that we would, in looking at all the guidelines, we use the minimum criteria for exposure. For instance, the WHO recommend close contact within 3 feet. We use the CDC guideline, which is within 6 feet. When, as far as close contact within 30 minutes of exposure, we use 15 and have dropped that to 10 minutes. So we try to use we try to be cautious and just to be careful that we identify anyone that could potentially be exposed. So someone with a direct exposure currently is defined as someone that has a positive COVID test or who has been clinically diagnosed with COVID, and you have been exposed to that person within 6 feet of them and for more than 10 minutes, up to 2 days prior to them showing symptoms. So considering that a person may actually have symptoms prior to showing signs, we go back 2 days prior to that first day of symptoms, again, to be extra cautious. And I'd just like to reiterate what the commissioner said. We approach each case individually. We have at least a 1-hour meeting on each individual case, and we are very thorough in how we evaluate, in trying to protect our staff and to not miss any potential direct contacts.
So Dr. Taylor, that process is called contact tracing. So for example, if we know that an employee, let's say on April 3rd, was last in a DCF office or facility, and now they have tested positive. Can you kind of quickly walk us through, using that April 3rd date of that person last being in the office, how do you determine who should be notified that may have been exposed to that individual?
So generally we have HR contact the individual to find out when they were symptomatic, and if they were not showing symptom on the 3rd, but say they started having symptoms on the 4th, then we go back 2 days, the 2nd and the 3rd. And we ask the individual to try to remember anyone that they had contact with, where they maybe had a conference, in-person conversation with, anyone that they've that shared a space that is within 6 feet. Those individuals are now defined as direct contact. So on the 2nd and on the 3rd. With an abundance of caution, we requested that those individuals be to self-monitor at home for 14 days. And it is very important to understand why we're choosing self-monitoring for 14 days with our contact. And that's because symptoms generally show up within those 14 days.
Those 14 days. So you take the date of when the person first started to show symptoms, you go back 2 days from there, and within that period of time, if that staff member has been around other individuals within 6 feet for more than 10 minutes, we believe that they should be notified as potentially being exposed to somebody who may have transmitted the virus.
Right.
Yep.
And we've, like I said, we change our guidelines as the CDC updates their guidelines, because now that we're in community spread, which is different than when we first started this process when we were concerned about travel. But now that we're in community spread, we've, our guidelines have changed too.
And as you said, we are taking a very proactive approach. Our Human Resources Department outreaches to the staff members who may in fact have been exposed, advises them of what's happened, advises them to stay home and self-monitor for 14 days. And this process is very fluid. And to use it as example, I think it was Saturday night that we were all on the phone till about 10 o'clock at night when we had a concern expressed to us about a representative staff member in one of our facilities, and we wanted to pull the team together and get right on it. So, Commissioner, with that being said, I think your plan moving forward as far as communicating with staff, updates about the department and what is happening around the state includes a weekly video, which we have here today, but also an all-staff memorandum to give staff an overview of testing and diagnosis in certain parts around our department and our response to that. Could you talk a little bit?
Yeah, and so what we had started to do was to notify, along with the people who had been identified in contact tracing individually, we started sending emails to the impacted office, facility, or division, and that will continue. The process that we just outlined, which also includes what cleaning has to occur, what type of cleaning has to occur, if there's any shutdowns or any of those things within a certain period of time, just as prescriptive as what Dr. Taylor just talked about in the contact tracing is a part of this process. And so the communication cadence started to get almost a case a day every single day. And what we were starting to hear were that we were contributing to staff's anxiety every time they heard of another positive. So what we've decided to do is that we will continue, of course, with this plan and this procedure to make sure that we step through all of those different components of contact tracing and following our procedures related to how we assess for the specific individual's needs, the support of any other staff members around them, as well as any community transmission issues. That will continue. We will also continue to notify locations if someone in their particular location has been tested positive, because as we see this continuing to ramp up, I think the last time I checked today, Connecticut's up to about 7,700 positive diagnosis for or positive tests or clinical diagnosis of COVID. So as that starts to ramp up, we have decided to not continue to contribute to additional anxiety by sending statewide memos every single time we have another staff member. What we've chosen to do is use this forum for me to give an update at the end of each of these videos as to the number of DCF staff across which locations, and I can update that on a weekly basis. So those of you who feel additional anxiety to hearing that information on a daily basis or much more frequently can choose to end the video before we get to the end of it and before I share where we are. Or those of you who really would like to know where we are as a department and get updates on the number of our staff who have been positive, you can continue to hear the whole video weekly all the way to the end where you'll hear that information. So I think that that strikes a balance with being transparent about the information that we share, as well as keeping people informed, but not contributing to additional anxiety, because we're all nervous and we're all concerned about our own physical health, our family's health, but also our emotional well-being.
Sure. And with 7,700 people in Connecticut now with the positive diagnosis, despite us as a department being very clear with guidelines and expectations to reduce, if all possible, that face-to-face interaction and contact, we do know that at times our especially our level 1 staff and those staff in our facilities are going to need to be physically with individuals in the community based on the nature of the report and circumstance or youth that they're caring for. Can you talk to us a little bit about personal protective equipment and what is being done to support those staff?
Yeah, so our facility staff at both Solent North and Solent South have been essential workers 24/7 because they're in a congregate setting way before the COVID crisis even started, and as have our Caroline folks. And even before I was in the position of commissioner, I used to always shoot a note to the leadership of those locations just to give appreciation for our staff who continue to work when the rest of the workforce either is home on a holiday or a weekend or after normal hours, or because of a weather-related incident. The folks at our facilities and at the Caroline are 24/7, and they have been. This particular crisis, because of the duration of it and how long it is anticipated to impact our state and our world and our country and our world, really required us to think differently about designating who can assist during this time in terms of our face-to-face contacts with the clients that we serve, whether they're in a facility or the people who typically get responded to by our Caroline primaries. And it became known to us pretty quickly that our Caroline primaries could not take on all of the investigations that occur during the day that come into our Caroline, nor could they assume responsibility for all of the concerns that happen across the state for the whole duration. So we made some decisions to add some groups to the level 1 responders that will help us make sure that we can keep up with the mission critical work that will continue to happen. And when I think about the type of folks that would have to have these in-person responses, I think about the work that I did for 18 years, Ken, and that was in investigations. As an investigator myself, as an investigation supervisor and manager, I know the qualities and skills of investigators. I know that we have certain ways of communicating, certain ways of assessing situations quickly, certain connections like to law enforcement within communities, and the ability to really synthesize information in a really quick way, and to make decisions and use our partnerships that we've had over the years. So, you know, I had heard out there that there was concern from investigators that the decision by administration to include investigators in our level 1 responders was met with anxiety, fear, and even anger in some places. And I even heard things like the administration must view investigators as disposable. And, you know, I want to use this time that we're talking right now to dispel that. If anything, I have deference for investigators because I've been one. And I appreciate the commitment of all of our staff, but I align mostly with investigators because of the amount of time that I spent doing that function of the work. And so when I think about having to have a portion of our workforce that still has to interface with the public or with the clients that we serve, whether it's in our facilities, whether it's through the help that our care line responders can give to folks, and adding this additional layer of area office investigators to that pool, I had to make sure that we had the personal protective equipment to be able to make sure that our staff were safe. So Dr. Taylor worked with our folks in engineering who are responsible for the ordering of supplies to make sure that we got cleaning supplies for our area offices, cleaning supplies for our cars, the appropriate cleaning for our facilities, sometimes bringing in some additional help with that, whether it's screening for temperatures, and having thermometers and those types of things, but also having different types of masks for the work that we do, different types of, we had gloves, we had hand sanitizer. In the beginning, it was really looking at what we had on hand within the department, and Dr. Taylor helped us do an inventory of all of the personal protective equipment that we had. We didn't have a lot, but that's what we started with. Then we were allotted an additional supply from the statewide stockpile of what was available to first responders across the state. Again, it wasn't a lot, and we had to divide it between all of our area offices and our facilities. And now there's certain protocols that are expected at the facilities when there is a positive COVID at those places that Dr. Taylor works with the medical teams at Solnet to ensure those procedures of isolation and cleaning go into effect at our facilities. So when we had to order some additional PPE, we had to also keep in mind that we have children placed in congregate settings. And so we had to order more PPE to ensure that our staff that potentially have to go into the field have PPE available, but then also some of the providers that we work with have at least some place they can call to ask to have some additional PPE. And so we're expecting actually another shipment of that within a day or so to hopefully make sure that we have enough supplies on hand for everyone. Our staff are still expected to go to court. We just recently developed a triaging process that those of you that have response within communities will see pretty shortly around the expectation of which types of emergency situations still require our physical presence, and as much as possible, making sure that the department has an understanding of what it is necessary to make sure that your needs are met, but also to meet the needs of our kids and families.
And Dr. Taylor, you authored a memo that was sent to all staff, I believe it was yesterday, about personal protective equipment. After I'm sure you were asked hundreds of questions about PPE and what is it truly utilized for and how does it protect us. Can you just briefly explain to staff the proper way to use PPE and dispose of personal protective equipment as well after its use?
So for our staff who are out in the community, the personal equipment that you probably be wearing would be of surgical mask. And that's a mask that covers your nose and your mouth. You may be wearing a goggles to cover your eyes and then gloves to cover your hands. It's important to understand why we've chosen those types of PPE based on how COVID infects you. COVID infects by entering your body through your nose, your mouth, and then your eyes. But it's or if it's on your hand and you touch your face. As the commissioner said, we've been working on getting equipment since January, and it is challenging across the state, across the country, and across the world to get these equipment. We, at this point, are trying to preserve the mask, and the memo that you mentioned talks about how to reuse them if they're still, if they haven't been torn or soiled. Gloves are not reusable and should be discarded after you take them off. And after you take off your gloves, they should be your hands. You should practice hand hygiene, the 20 seconds of washing with soap and water or with a hand sanitizer. And the video also goes through how to do that. It is important when you wear your mask to, and I wish I have one to demonstrate, but it's important to remember to touch the strap of your mask that goes over your ears or goes over your head, and not to touch the front. When you're taking it off, you should always take off by the straps. So after you've taken off your gloves and sanitize your hands and you're taking off your mask, remember that the front of your mask may be contaminated. So you don't want to touch the front, especially as I said, if you sanitize your hands, you want to make sure you do not touch the front of your mask and reach behind and touch the back. Do not touch the back with your gloves because we're clean back here. So you want to sanitize and then take off that mask that way. And also, one of the things that I hope the mask does is it helps create a barrier so we don't touch our face. I think it's been challenging in the last 2 months to remember to not touch anywhere on your face, but if you have gloves and mask on, that hopefully is a deterrent.
Great. And so again, wash, soap and water for about 20 seconds. And even I think we understand that when there's been an individual who's tested positive in a facility or an office, a cleaning crew does go in and does a terminal cleaning. Which means wiping down surfaces, doorknobs, desks, phones, because the virus is that easily transmitted, but also that easily prevented from being transmitted with those basic precautions that we hear the commissioner consistently document in the all staff memos and Dr. Taylor, what you just said here. Great.
It's important, Ken, before you leave the issue of PPE, it's that, just recently this week, the CDC made the recommendation of all staff, of all people wearing masks all the time. So people have created their own type of cloth masks. Dr. Taylor just talked about some precautions that we have included in the distribution of the PPE that we have. There's that memo that she just referenced where she steps through all of the different types of protective equipment. In that memo, there is a YouTube video that's short that talks through the proper way to take gloves off, the proper way to apply the masks. And so what we would say is that anytime you've had to have direct contact with each other in the course of your work, or direct contact with our clients, whether they are children in our facilities, or if you are called out to do work, it's not a recommendation. You must have PPE with you in order to have your own protection and the protection of continuing to transmit the potential of any type of bodily fluid. I would also venture to say that as we continue to acquire a little bit more PPE, if you are dispatched to have to respond, have also gloves and masks with you that you may either ask the person who you're going to be interfacing with to cover their nose and mouth. And if you don't have additional PPE with you, to ask someone to cover with a t-shirt or a scarf or some way to create a barrier between yourself and the person that you're talking to, and to create that 6 feet distance between you and the person that you're communicating with. This is so imperative and so important in terms of social distancing and trying to keep ourselves safe through this, because the reality is we are responders and we are helpers, but we also have to learn ways to be able to protect ourselves beyond universal precautions. These are additional measures that we're putting in place to try to ensure your safety.
Great. And Dr. Taylor, any last thoughts on use of PPE or utilizing PPE?
I just want to kind of reinforce what the commissioner just says. This works. Wearing a mask and creating physical distance of 6 feet or more works. If you think about how the virus is spread and the fact that you can either spread it from talking, coughing, and sneezing, when you're wearing a mask, it prevents that projection of the virus. And we know that the virus projects and then falls. So that 6 feet space creates a physical distance that makes it less likely for you to transmit the virus. And what I like to think of is we're being socially responsible when we wear a mask and protecting those around us. And so we're asking our neighbors, the person in front of us, to also be socially responsible and do the same for us. So we're all, wearing something that covers our nose and our mouth.
Great. Great. So one additional question that now has come up in our work is the department's response to the Family First COVID Response Act.
Yeah.
And so, Commissioner, we know there's going to be some guidelines coming out about that from your office. Can you explain to us what the department's position is?
So Governor Lamont issued a 14-day dependent care leave for folks that had either children to care for or elderly to care for, as well as any concerns related or associated with COVID. That 14-day still remains in effect. The federal government and the act that you just referred to issued guidance to states related to that particular act. And so our HR department sent out the information in the memo last week, I think it was on April 1st, about the availability of that additional leave, additional federal FMLA related to dependent care. One of the things that the federal guidance subsequently sent to us that we had to get clarification on from the Office of Labor Relations is that there is a carve out for specific entities who would be exempt from utilizing that federal FMLA is what we'll call it. And child welfare workers are listed as an exempted agency, which means that we as an agency had to opt out as an agency as a whole from the ability to take advantage of the Federal Family Leave Act. What that means, though, is that because we are still super concerned about your ability to take care of your own families and your needs, we will be still looking at your requests at an individual basis. But when you see the memo that's about to come out related to the federal FMLA, it's because there is a carve out related to certain levels of first responders, like state police, like law enforcement, that would be exempt from that particular federal FMLA. Please, if you have independent needs, contact your local HR and they will step you through the process for having that evaluated on an as needed basis. The department is looking at everything we can to really try and assist staff through this time with the teleworking, with the ability to flex the hours of when you are available to do your work, and creating rotations in certain divisions to create more physical distance in an area office or in a division, minimizing the number of hours a particular division is open, creating screening processes at the beginning of shifts. All of those things are to minimize our footprint in the transmission of this disease. And, as we learn more, we add more to the layers of protection to try to ensure that our workforce is responding appropriately to the COVID issues, and we are trying to minimize not only exposure to our staff, but also our participation in the transmission of this virus.
Great, great. So as we wrap up and start to end our video, I'm going to ask Dr. Taylor and Commissioner, I'm going to ask you this, and then if you could end with the statistics that you had mentioned you were going to talk about statewide. Dr. Taylor and Commissioner, language really matters here about how we are communicating with our staff, what we are communicating. Dr. Taylor, what is, in your mind, something very important that we haven't covered yet tonight, or that you want to reinforce that staff should know and remember and take away from this video?
What we have been doing over the past 2 months have been working. It may not, I don't know that that's very visible, but as the commissioner mentioned, the telecommuting, the social distancing, when we evaluate our first case versus later case, we realized that for the staff, there has been less of our footprint in transmitting, or the possibility of transmitting this virus. So what we have been doing has been working. And the last thing that I'd like to say, that as the commissioner mentioned initially, this is unprecedented. We have no experience, we've not experienced something like this before, but we're succeeding because we're working as a team. And the over 3,000 DCF employees, we're all a team. We're all going to succeed because we have been working as a team and will continue to do so.
Commissioner, your thoughts?
Yeah. So the work itself goes on. I just want to make sure people know that our care line has accepted for the month of March an additional 6,554 calls. That then translates into 4,551 reports. And so when you think about the work of DCF and you think about the experiences of families within communities in Connecticut, they know that they can count on DCF to be part of that helping community. What I want to say to our staff is that I understand, I feel, I fear, and I sympathize with those of you who have lost loved ones and those of you who are experiencing the impact of COVID-19 within your own friend and family network. We're going to continue to talk with you weekly. I encourage you to look at the daily newsletter. I encourage you to visit our resources on our website, which, by the way, has been accessed close to 9,000 times by people looking for information related to COVID as it pertains to child protection issues. Those unique people, those over almost 9,000 people that have reached out to our website, have accessed it over 12,000 times. So there is a thirst for information and knowledge. And if there's something that we can do to share with you, concerns that you may be having specific to our work, please send it through the COVID-19 mailbox that's off of our website that we've created to hear from you and to hear from the community. And then the last thing that I would say, Ken, of the number of staff that are impacted by COVID-19 right now with a positive diagnosis, we are up to 15 across our area offices and our facilities, as well as our central office division. So we are up to 15, and those 15 staff have had contact tracing, and the people who have had contact with them for 10 minutes or for at least 10 minutes within that 6-foot space that Dr. Taylor stepped us through were contacted from a notification standpoint. And then the protocol that's put into effect of either having sent home for the 14 days of monitoring and additional cleaning that has occurred at the locations in which those individuals worked has gone into effect and will continue to do so out of abundance of caution. Again, this is a virus that's easy to kill, but it's also easy to transmit.
Great. So, Commissioner, moving forward, this is certainly your weekly video. I think the plan is to provide staff weekly videos in the near immediate and longer term future to confirm information, answer questions. I'm sure at some point Dr. Taylor will be back with us, or other individuals, depending on the nature of the questions. So thank you so very much, both of you, for spending the time to do this video and engage in the conversation. And we certainly all will talk soon.
Thanks, Ken.
Thank you, Ken. Thank you, Commissioner.
Bye-bye, Dr. Taylor. Thanks.